second. Where is my screen? I could not. Yeah, it is okay.
Okay. Good evening, everyone.
Good evening. Yeah.
Good evening, sir. This is Dr. Sunaina from HCG Bangalore third year resident, sir. Shall we go ahead?
Madam, we are going to have 25 questions, starting with very basic physics questions, which minimum radiation oncology should know in clinical point of view, and few questions on advanced radiotherapy, like just a basic things, like what are the advanced questions, their uses and all.
So, please take your voice breaking.
Okay, sir. Change my better. Give me 1 second. Give me 1 second. Hello.
Tell me.
Sir, can you hear me now?
Clear.
Is it okay?
Yes, sir.
Okay. Okay. So that's what, madam. We have few basic physics questions, and then we have some questions on advanced equipment. And finally, the last question was the last few questions are related to radiation cycle. So it's a very basic, simple. Okay. So your first question is, what you can understand from these pictures?
Sir, this is different interactions of the radiation with the matter, sir. The first image is showing the Compton effect, sir. So by the image, we can say that the photon, when it interacts with the free electron, so there is a after the interaction, when this photon loses its energy and this electron is like removed from the shell. So based on this, we can say it is Compton effect, and it is mainly seen in high energies or high atomic high energies. So mostly this is the most common one we are seeing with the radiations and megavoltage energies. And the second one we can see here is we can see one positron and electron. So this is the pair production. So mainly this pair production occurs when the threshold energy is more than this 1.02 MeV. So after this, when this happens, it releases one positron and this electron. So later, when these ejected photons, which are released, this positron or electrons releases or lowers its energy, this positron may interact with the free electron, and that process is called annihilation reaction. So that is the process which we usually see in the PET. And the third one we can see here, it's that photon is interacting with the inertial electron and it is ejected out. So this is the effect, is the photoelectric effect, and it's mainly what we are seeing in diagnostic radiology, and it is mainly dependent on the atomic energy. So that's why in the diagnostic images we will see the difference between the bone and the soft tissue. It's mainly dependent on the atomic numbers.
Okay. So you see Compton effect in Compton scattering in diagnostic radiology?
Sir, it's mainly predominant in because in the diagnostic we will be using low energy, sir. It is mainly predominant in the higher energies beams. So the higher energy, which are the megavoltage, we'll be using for the therapeutic radiation. So we'll be seeing more in.
No, I'm asking, do you observe, do you see
no,
scattering
sir.
in diagnostic radiology?
No, sir, because it's not, it is independent of the density and the atomic numbers. Compton effect.
Actually, you can see Compton scattering in radiology also.
Okay.
So the photons which are scattering from the patient body, which causes unnecessary dose to the patient and unnecessary dose to the personals, that workers, like the technicians and the surrounding. And it will reduce the image quality also. See this Compton scattering is there in radiology also, but as you said, more predominant is photoelectric effect. This Compton effect is like a disadvantage in diagnostic radiology because it reduces these scattered photons will fall on the detector and it will give the less contrast to the image.
Okay, sir. Okay, sir.
Whatever the scattered dose from the patient. So you are having surrounding dose, na? In the X-ray room, you have surrounding dose. That's the reason we have lead door and lead viewing glass.
Uh,
So these are
yes, sir.
because of these what we are just protecting from these photons only. Control
Okay,
scattered
sir.
photons. So
Okay,
can you
sir.
tell
Okay, sir.
something about PET principle? Came to up to annihilation level, but after that you missed just only 1 cent. I'm expecting that. What happened after annihilation process?
Sir, after that, the energy which is after the annihilation reaction, the energy will be produced in the form of light, sir. This will be captured in the PET machine, and that will be visible in the images.
Yes, you will get two photons which are traveling 180 degree from each other. Am I right? So this will
Yes,
be
sir.
captured in the PET CT.
Yes, sir.
The principle is different. The pair production process you can see in the PET CT. Okay, good. So can you tell one more point? Is Compton effect is depend upon jet?
It Compton
Yeah,
effect
am I clear?
has
Because I'm getting some messages. My voice is breaking.
a
My
little, sir,
voice.
not too much.
Go sir. Okay. I changed my earphones also. Let us. So what about?
Sir, Compton effect does not depend on the atomic number, sir.
Okay, it depends upon what?
Energy of the beam, sir.
What else?
And
Depends upon mainly one
ele-
point.
electron density and the beam energy, sir.
Yeah, this depends upon electron density. So where do we use this one, Compton scatter?
Sir, mainly,
Where is this electron density is very, very important.
sir, in the diagnostic imaging itself, sir, example is the bone or the soft tissue. That difference we can see more because mainly it depends on the electron density, and the bone will be having more and soft tissue will be having less. So it will be better.
So can you answer me? Can you tell me one point? Why do we do radiotherapy planning on CT images? Can we do it on MR and X-ray based images? Is it possible or treatment planning on MR or PET or X-ray? Is it possible?
Sir, planning can be done on the MRI also, sir, but the software, I don't know exactly, sir.
Okay, no problem. So planning has to be done on only CT image because it contains electron density information. Okay. Actually, it has He value. We will convert that He value into electron density, like a CT to ED file, we call it as. So, TPS contains, along with the He value, it will convert the image into electron density. So, the Compton scatter is more predominant in the megavoltage beam, the radiotherapy beam. So, we do planning on CT images only. In the case of MRI, it is photon density. It's not an electron density. Compton scattering depends upon the electron density, proportional to electron density. So we can do only planning on CT images. So we cannot do an MR, ultrasound, or
Your voice is not audible.
okay. Okay, sir. I switched off my fan also. Let us see.
Now it is clear.
Okay. No issues. No issues, sir. Thank you. So,
People are
sorry for
asking,
the.
can you repeat?
Yeah. So we can do treatment plan in only CT images because this CT images contains electron density information. Really, it does not contain electron density file, but there is a relation between CT number and electron density, which we input in the TPS. So while importing an image, we will apply CT to electron density conversion file. So that it converts the He values into electron density values so that I can do the planning, because Compton scattering is the more predominant in the treatment delivery. So I have to do planning on any image set which contains electron density. So CT images only can contain electron density information. So we cannot do plan on MRI and ultrasound or X-ray. Some people may ask, how can we do like a brachy planning on X-ray or what is this, MRI and all? Yes, brachy planning is not at all using anything. It is not at all using the medium and all. The brachy planning is as per TC 43. It is doing entire calculation. It is considering it as a water. Whatever be the, it is an MRI image, or whether it is an X-ray based image, whether it is applicator is in the air also. If you reconstruct the applicator, after reconstruction, if you use it for calculation, after activating the sources, if you do the calculation in brachytherapy, the entire calculation will happens based on it will consider the surrounding medium is water. It is not at all consider what image it is, what heterogeneity, what are the densities are there surrounding the applicator, nothing. Surrounding that applicator, it is completely the completely medium is water only. So that we can use any image in brachytherapy. Like if you are able to do it in with X-ray based, with MR image also, you can do brachy planning, but not in external. So can we go to next question?
Yes, sir.
Madam, can you speak something about this picture? Can you identify the parts? Can you explain whatever you know?
Yes, sir. This is the this is the mainly image of the production of X-rays, sir. So the first here we can see here the numbering is not there, but this is the one towards the arrow side, that is the cathode one, and this blocked line towards this electron where it is mentioned, this is the black one, is the anode hood, and this is a filament where it is there, it's tungsten filament, and the target is also where the electrons are hitting, that is also it is tungsten target. So mainly what we are seeing here is thermoionic emission. Based on that, the production of X-rays will be produced.
Yeah. Can you tell me, can you explain me how the X-rays are produced very shortly? Like
Yes, sir. When the current is passed through these electrodes, so this filament is heated, sir. When the after the heated element generates this based on the thermoionic emission which I had told, so the electrons will be produced, as this electrons will be traveled from cathode towards the anode side, because this anode's hood is towards the side. So after traveling it, it hits the target, which is made up of this tungsten, and from there, after hitting, X-rays will be produced, sir.
how, madam? How the X-rays are produced? When the electrons hitting the target, how the X-rays are produced?
This when this high-speed electrons bomb, I mean, it hits the target, the energy will be released, sir, by mainly Bromstall.
Hello?
Yes, sir. Yes, sir. Mainly based on this Bromstall and characteristic radiation.
How these X-rays are produced?
Sir, when it hits the target, the electron, I don't know exactly.
Okay, no problem. When just I will explain with some pictures. Yeah, you can see here. So these are the parts of the X-ray tube. So this you can see my cursor, no?
Yes, sir.
This is the filament, gun filament we call it as. Okay, it's a tungsten filament. It has high melting point and very high resistance and very thin and long. So when current passes through this filter, because of high resistance, the electrical energy converted into heat energy, it heats the filament. So it will boil up the electrons will come out from the filament. Okay. So these electrons will travel towards the anode because the anode is having a positive charge. And to gain an energy, we apply some voltage, tube voltage we call it, between this anode and this cathode. We apply some voltage difference, potential difference. That is the, if you apply 70 kilo electron, say kilovolt, the electrons will gain 70 keV kinetic energy. If you apply 100 kV kilovolt to potential difference, these electrons will gain 100 keV electron volts kinetic energy. The high speed, high kinetic energy electrons will travel and hit the target. When they hit the target, and I will explain that one. Once this is one of the focusing cup. Some people will say focusing cup. Some people will say cathode cup. It has a negative potential, and we call it as a focusing cup because it focuses all the electrons. Even because of the potential positive polarity at this anode, the electrons are traveling. To make it more focused, this cup will help us. This cup is called focusing cup or cathode cup. It has negative voltage. It will focus the electron beam at one spot. We call it as a focal spot. So this will help to focus at a small area. Okay. Now what will happen? This high kinetic energy electrons traveling and hitting the target material. What happening in the target material is this one. When the high kinetic energy electron travel is coming close to the atom of the tungsten, when it comes to close to nucleus having a positive charge, this positive charge attracts these electrons of which is negative, because this is positive, this is negative. When it attracts, these electrons start slowing down because of this attraction. As it is slowing down, its kinetic energy reduced. That means it has to lose some energy. That energy is emitted as a form of X-rays. That we call it as a braking radiation or Bremsstrahlung radiation or white radiation. There are three names. So the loss of kinetic energy because of the nucleus attraction force by this electron is called Bremsstrahlung X-rays.
Reaction.
This is one method. This is one way of losing energy. Electrons losing their energy in the form of X-rays. This is the more predominant. If you see an X-ray beam, more is Bremsstrahlung component will be there. And second method, another method also there, is a Compton scattering, where the electron will come and hit the orbital electron. Okay, this electron will be ejected. So there is a vacancy will be formed. So the higher electron from higher energy level jumps to lower energy level to stabilize this atom. While higher energy electron jumps to lower energy level, it has to lose its whatever the excess energy it has in the form of X-rays. That X-rays we call it as a characteristic X-rays. Why we call it as a characteristic X-rays? Because the energy difference between this K shell and L shell, or the K shell and M shell, is specific for that target material. That's why it is the energy of the characteristic X-ray is depends upon your target material. You change anything like potential, tube current, nothing will this characteristic X-rays energy will not change until unless you change the target material. If you change another, for example, if you took molybdenum, then the characteristics peak will change. The energy of the characteristic X-rays peak energy will be changed. So this is the characteristic of the target material. That's why we call it as a characteristic X-rays. So, okay, how the energies, high energy electrons loses its energy in the form of X-rays. Understood, madam?
Yes, sir.
Yeah. So this is the answer. Madam, can you identify the picture? Can you say something about what it is? The advantage, disadvantages. Have you ever experienced it?
Yes, sir. It is a Cobalt 60 machine, sir. What we can see here is the source, which is mentioned here, and is the source head, the collimators, and which is covered by the tungsten hood, sir.
It's not tungsten hood, madam. Oh, this one you are talking. Okay, okay.
Yes, sir.
Hmm.
And
Yeah,
this
no need
now
to
the source is in off. In this image, the source is in off position, sir.
Okay. Say something about this telecobalt machine, whatever you know, ma'am. So you can tell what is the energy? What is the radioactive source, madam?
So it's cobalt.
Cobalt? Any
Cobalt
number is
60,
there?
sir. Cobalt 60, sir.
Okay. What is its half-life? What is its energy?
Sir, the half-life is approximately 5 years, sir. It's 5 years. And the energy is average energy of the, because it is 1.25 MeV, sir. When this radioactive cobalt comes to its stable position, nickel, it releases two beta rays, sir, which of two gamma rays, which of the energy 1.17 and 1.33. So the average is 1.25 MeV is the energy of the cobalt, sir.
Okay. So any idea about what is the PDD at 10 centimeter depth or do you have any experience, clinical experience with cobalt?
No, sir. I haven't not any clinical experience here, but as like theoretically I know about this. So
Okay. So what is the SSD they use?
so 80 centimeters, sir. 80 centimeters, and Dmax it will be around 1.5 centimeters, sir. At 0.5 centimeters, and at 10 centimeter depth, the PDD will be around 50% isodose distribution, isodose curves.
50%.
Yes,
Okay.
sir.
You are telling all the things roughly. Okay, no issues. And any idea about like it, mm, particularly about safety thing, safety issue, or any advantage over LINAC? So what is the source size? Any idea how the source is?
Sir, 4 centimeters is around 2 into 2 centimeters, sir. And it will be mostly cylindrical source, sir. And it will be in the form of the pellets inside it.
Yeah.
The head, sir. And this will be having this emergency alarms and also the safety measures. So
What is the main difference between linear accelerator and telecobalt machine? Say some few differences.
so this is
You have
the
experience with
gamma.
linear accelerator, am I right?
Yes, sir. Linear.
Yeah.
So this is gamma ray radiation, sir. The linear accelerator, it's X-ray, and this will be having this because the source is in position. There will be continuous emission of the radiation, sir. In LINAC, it will be
It
only.
is a radioactive source, so it continuous emission of radiation.
Yes, sir. Yes, sir. In LINAC, it will be like production. So when the treatment is beam is on, only that time.
Yeah, when you switch on the machine beam on, then only the radiation will come.
Yes, sir. And this collimeters also now they told it advanced ones, MLC based cobalts also has come, but previously the main things are the fixed collimeters and the custom blocks will be used. Now in the Linux we can use this primary and the secondary, I mean JAWS and all. Trimmers will be there in the cobalt, sir.
They are not in all machines. To reduce the penumbra, they use the trimmers.
Yes, sir. And
what is the maximum minimum field sizes in cobalt machine?
Don't know, sir. 40 cross 40 or no?
No.
I don't have ideas.
If I'm right, some of the answers you are seeing the messages and you are telling. No? Is it right?
Yes,
No.
sir. I don't know the
Because
answers.
don't look at their answers because they are also like you only. So please, I
Yes,
observed this one at the starting itself, but okay, don't look at their answers. See, it's normally 30 by 5, 35 by 35 maximum field size. And
okay.
minimum field size is 5 centimeter by 5 centimeter because you cannot completely close like LINAC. Even LINAC also we cannot close completely. The minimum field size is 5 mm by 5 mm in LINAC. But in telecobalt machine, 5 centimeter by 5 centimeter. The minimum field size. The maximum is 35 by 35. In LINAC, you know very well accessory is 100 because that is a completely X-ray based. So the dose rate, whatever you want, you can increase or decrease. Whatever you want, you can do it. But in cobalt, you know very well, the output is constant. Means, yeah, as the source decays, output will reduce. That is the reason they brought it to smaller SSD, 80 centimeter. In LINAC, it is and in the LINAC, you have multiple energies like 4 MB, 6 MB, 15 MB. And in LINAC, you can have electrons also. But in the case of cobalt, you have only photon energy. And in the beam, the penumbra is more in the cobalt beam, like 1.5 centimeter almost it will be there. But in the case of LINAC, you will have 7 to 10 mm. That means 0.7 to 1 centimeter penumbra. Penumbra is less in LINAC beam. So let us just we'll go further. So these are the parts you have. Like as you said, not in all the machines, but most of the some machines having tremors to improve the penumbra. That means to reduce the penumbra. So there are different shutter systems also there to block the source, and we call it as a source dryer. This source dryer will bring the source to on position and off position. And in the case of emergency, when the source is on, there is a small rod, it will come out. If you see from the CCTV camera, because when the beam on, when the source is in on position, you cannot be inside the machine. So if you see through CCTV camera, one rod will come from here, will come out here. If there any case source struck, even if you after complete predefined treatment is over, if the source is not gone back, means still the rod is outside only. That time we will use T rod. Any idea about T rod?
Yes, sir. It is used to place the source in the position, sir, when it is
when there is an emergency, when the source didn't go to its safe position. So that means this rod is still outside. So you have to go and insert your T rod into this rod and you push it hardly until that white one should be there. The white color should show here only. That red and yellow should be completely inside. Okay, next you can go to. So this is the typical Teratron 780 Cobalt 60 machine. This is a very good machine. They are very strong, and these are the first machines, first generation machines. So can you say something about these machines? First, explain some components.
Yes, sir. This is the linear accelerator machine, sir.
Okay. What is first one? What is second one? What is this first figure? What is the second figure?
Sir,
what is the first image?
Sir, this is linear accelerator with the one is IPID, sir. One is
this is variant machine. This is an Electra machine.
Okay, sir.
I don't know whether you have what is your experience, madam, with Electra or variant? Because you should know. This is also linear accelerator. This is also linear accelerator. This is from variant. This is from Electra.
Initially,
both
when
yeah.
We had variant, sir. Variant linear accelerator.
Okay, good.
Electra, I didn't see.
This is the Electra machine, madam. This
Okay,
is the Electra machine. So now, can you explain something about this? So what is this? What is this? What is this? What is this? What is this?
Yes, sir. This is a treatment gantry, sir. And this is the down is the no, it's like a beam stopper, and this is the to take the.
Which one is the beam stopper?
Down one, sir, opposite to the gantry.
Collimator. Okay.
Collimator, opposite to the collimator. And
that is not a beam stopper, madam. That is EPID, portal imaging. 2D verification. We will take MB imaging and we will match it. That is EPID. It is not a beam stopper.
Sir, this parallel to this, perpendicular to this, that image will be taken with that, right, sir?
No, this one, you can see my cursor. This one you are talking, you said it is a beam stopper. Am I right?
Yes, sir. Yes, sir.
This is not a beam stopper, it is an EPID. We call it as a
Okay, sir.
portal imaging panel. To MV imaging, we
Okay.
take a 2D imaging.
Yes, sir. Yes, sir.
We will mark the bony mark and we will match it with DRR.
So the beside one which is there,
This one is KB imaging.
heavy imaging. Okay, sir. Okay,
CBCT.
sir.
Onboard, in the variant they call it as onboarding imaging. In Electa, we call it as XVI or CBCT.
Okay, sir.
In variant, you call it as OBI, onboarding imaging. This is an X-ray tube. This is the detector panel.
Okay, sir.
So this gives the 3D information. CBCT.
Yes, sir.
The same way in Electa, this is an X-ray tube. Actually, the cover was removed here. There is a cover actually, and these are the X-ray tube. This for CBCT, 3D verification, KB imaging, and this is the corresponding panel, and this is the EPID panel. You can see my cursor, no?
Yes, sir.
This is the EPID panel. This is the collimator. This is the gantry pouch. So you can say something about linear accelerator. What is the maximum field size? What is the minimum? What are the energies? You say something like MLCs. What are the MLCs you know? What is the advantage of LINAC over conventional linear cobalt telecobalt machine?
Yes, sir. Through the linear accelerator, we can treat with both X-rays and electrons also, sir.
Okay.
And we can use with the different energies starting from 6 to 15 MV photons, and we can use, as you told, like MLC, so that we can use for the beam shaping and field shaping to treat the target like accurately. And
Okay. Can you say something about MLC in depth?
sir, it's a multi-leaf collimator, sir.
Okay. So
Mainly
you
it
had an
will be,
experience with Varian, am I right? So which machine you have, which MLCs you have, what is the advantage and disadvantages of your MLC?
um,
Because as a clinician, you should know whether you can use it for all cases. What is the advantage of your MLC, disadvantage of your MLC?
sir, we had multi-leaf collimator, sir, which
Oh, that is
had this.
एंड चोद क्यों कर रहे हैं ये क्लास अटेम्प्ट
Sir, which has the leaf thickness of 5 mm is this dynamic collimator, sir, which I had experience. So it will be
okay. Throughout
dynamic
40
throughout.
centimeter, 5 mm is there, or middle only 5 mm is there. Middle 20 by 20 only 5 mm is there. All the leaves are 5 mm leaves.
Sir, actually, when we joined initially, like it was there, sir. They later they dismantled it off. I didn't have much with the basic
Okay.
initial.
So I think Millennium 120 MLC is there, where in your variant, like first 20 by 20, middle 20 by 20 is with 5 mm leaf thickness at isocenter, and outside the range, like outside this side, another side 10 centimeter, another one side 10 centimeter, that is 1 mm, 1 centimeter leaf thickness. And you have HD MLC, it's a maximum field size itself 40 by 28 or something, 2.5 mm, 2.5 mm leaf width at isocenter. So you should know very well about your MLCs, because based on that one only your plan quality or something you can do. Because you should understand, for example, whether you can do it SRS or not with your LINAC. So the plan quality, everything. So please try to understand about MLCs. Okay, if you have in the Electa SLT, we call it as the entire 40 by 40 field size as having, that is 160 pairs. That means one side 80, another side 80. That means 5 mm at isocenter. But variant it is not like that. Middle part in the Millennium 120, middle part only, middle 20 by 20 only 5 mm slice thickness. The outside one 1 centimeter thickness. Okay, madam. So what
Yes,
are
sir.
what are the photon energies you have seen in your linear accelerator? Someone is asking, can you repeat it? Okay, just give me 1 second, madam. Someone is asking. So you should understand about your MLC of your machine. because your plan quality or the technique what you want to select is very, very important. For example, you want to do SRS, so whether you can do it or not in your machine. So these things is depends upon your MLC. For example, you have only 1 centimeter MLC, you cannot use it for SRS and all. Okay, and if you have 5 you can use it for certain cases, but not for all SRSs. Okay, if you have 2.5, you can use it for most of the tumors. So Varian having Millennium, there are, as of my knowledge, because I'm not a Varian customer, but as of my knowledge, I'm telling, Varian has 2 models of MLC. One is Millennium 120, second one is HD MLC. In the case of Millennium 120, and the entire 40 by 45, the middle 25 by 20, 20 by 20, having leaves of 5 width at isocenter. So other both sides, the remaining this side 10, having 1 centimeter leaf width at isocenter. So middle only 5 outside 10 that means 1 centimeter. But in the case of Electra, we call it as agility. It has a 40 by 40 field size. It has completely 5 that means this side 80 pair, this side 80 MLC, this side 80 MLC, total 160 MLC. They are having leaf width at leaf width 5 at isocenter. No, depleted uranium is, someone is asking. No, they are not using any depleted uranium. Planar does not contain any depleted uranium items. So can you say something about, or shall we go to next question? So can you say something about CBCT? That means onboarding image.
Sir, in the
What is-
CBCT, which we are taking, either we can go with the KV CBCT or the MV CBCT, sir. But if for the daily imaging and proper matching,
You
if
have
it is
MV CBCT with variant.
not with variant, sir. Normally, I am telling, sir, in the machine CBCT.
As of my knowledge, with variant and Electra, we don't have any MV CBCT. Sorry, we don't have. We have only, we have, with MV, we have 2D imaging.
No,
So it's only 2D imaging. With only KV source only, we can do CBCT like a 3D, cone beam CT.
no, I mean, in our institute, actually, one new machine has come, sir, Halcyon from the variant itself. Like,
Okay.
it
Okay,
has
good.
MV CBCT, sir.
MV CBCT, okay. It has a, okay,
Yes.
I don't have an experience with
Yes.
Alcyon, I know, but I don't know about MV CBCT. Good. Then
So
good.
based on that image clarity will be better with the KV CBCT, sir.
Yes.
So for daily imaging purpose, it is better if the machine has the KV CBCT and
Okay.
with the treatment with the mega voltage beams.
So what is the difference between this KV, CBCT and CT? Any idea? What are the similarities and what are the differences?
Sir, in the image we are taking here is that the cone beam one, sir, because but here it in the CT it will be like a fan beam. That will be the difference, and
That means this is the difference. So okay. So any
And-
other difference? What because of this one, advantage or disadvantage?
sir, cone beam at a time we can take the full
Entire volume in one rotation we can
in
take
one
the scan.
rotation we can take the scan, sir. Yes, sir.
Good. It's an
And
advantage.
it's an advantage, sir.
So is there any disadvantage?
Resolution, any
As you are
resolution
taking the CT scan slice by slice, the resolution will be higher.
Yes, sir. Yes, sir.
CBCT, the image quality will be lesser. Because you are taking entire volume imaging at a time and making it as slices. So the resolution will be decreased. The
Yes, sir.
image quality will be decreased. So you know what are the photons energies you are using?
Yes, sir. In our center, it's mainly the 6 MV mono. I mean, only
Single energy Linux.
single energy. Yes, sir. Yes, sir.
Okay. So as a clinician, if someone is asking you to select machine with multiple energy or single energy, which is better?
With multiple energy, it will be better, sir.
Why?
Sir, if it's more depth lesions and all, if it's higher energy, the penetration will be better and the dose coverage will be with the deep-seated tumors will be better with the high energy beams, sir, more than 6 MV.
Yeah, based on your tumor depth, based on your surface dose requirement, you can choose your energy. Like 4 MB, if you want surface dose, you can go ahead with
Surface
4
dose,
MB.
yes. Yes, sir.
If it is a deeper like thorax and pelvic cases, you can go for higher energy.
Yes,
Okay,
sir.
good. So electrons, what electrons you have? Oh, you told me that is single energy machine you have.
Yes, sir. All are gantry based. I mean, what is that? Not like a linear accelerator, sir. Everything is like round. What is it? Rotational gantry based. Initially, we had Linux, sir. I had seen 2 cases treating with the electrons. It has different energies, sir. Like starting from 6 to 12 to 15 MeV. It was there, sir.
So please, as a radiation oncologist, you should know the complete specification of your machine, because you are the doctor. You are going to decide which energy you are going to use it. Don't depend upon completely physicist. You may have experience or he may has experience or not. So what photon energies are available? What electrons energies are available? What energy is suitable for your case? So while evaluating your plan, so you should understand whether the physicist used correct beam direction or not, and correct energy they used or not. Because if they don't know, they don't, for example, junior physicist joined, he's a fresher. You just gave a just physics, just you gave a simple palliative case. So that is tumor is not at the midpoint or it is a midpoint. Instead of 15 MV, he selected 4 MV. So it's not good, no? Or if it is at one side, like it's almost towards the posterior side, but it almost coming towards sorry, it is a anterior side. It is almost come to mid level. So one side he can use 4 MV, another side he can use 15 MV. So you should know about LINAC specifications. What are the photon energies? What are the electron energies? What are the additional features you have, MLCs particularly, and what imaging modalities you have, whether it is couches 3D or 6D. So this is a very, very important.
Okay,
Next.
sir.
So these are the, so can you say just simply about, so I gave the picture. Can you explain the second picture? This is a linear accelerator working principle. Can you make it
Yes.
faster? Because we are already late, I think. We are very, very late. So
Yes, sir. This we can see here. Actually, one more thing, power supply has to be here, sir. With that, and what we are seeing is the modulator, and this klystron or magnetron or microwave power source and or amplifier. So these microwaves are generated from here, sir, and
okay.
generated or amplification or acceleration will be, will be done here with the pulsed modulator. And after this, through this electron gun, electrons will be generated, and this will be passing through this accelerating waveguide, sir. After
Okay.
this microwaves will be passing through this, so this will accelerate the electrons to the higher frequencies with the so that it will travel to the higher velocities. So after
Okay.
entering into that, all will be of these will be aligned uh, based on these focusing coils, and the steering coils will be there around this accelerating waveguide, sir, so that it will
Very good.
go in, and it passes through this bending magnet. Once it passes through it off, it goes through the source head or the treatment head, which has this target. So it hits the
Okay.
target. After hitting the target, the x-rays will be generated, sir. So in the
Okay.
place if the target is not there, through the scattering foil, we only the we can treat with the electrons.
Very
So
good.
after that, we'll be having the primary collimator, and then um, we can place the
Very good.
flattening filter between
What
the.
is the use of primary collimator? Really?
So the field size will be based on the primary collimator, sir.
No.
Uh,
Primarily just it collimates the beam. That's all. Approximately it
okay, sir.
collimates the beam.
Collimator.
Because after hitting the target, the X-rays will come like a broad manner. So primarily just you are collimating. Like
Okay, sir.
approximately you are collimating something. That is not
Okay.
the final collimator.
Okay.
Approximately you are collimating using like a using primary collimator.
Okay, sir. Okay,
Then
sir.
next.
Next, actually, in between primary collimators and the next will be the secondary collimators. So in between, we
No,
can
no, 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 no. So
flattening.
yeah, slowly explain one by one, because here is very, very important. You should
Yes.
know this one. After primary collimator, what it is there?
Flattening filter can be
Okay.
placed, sir,
Yes.
so that actually the photon beam, whichever will be produced, had the forward peak, sir. So
No.
in order to get the flattened beam,
Yes.
we will use the flattening filter, sir, which is the cone shaped, so that it makes the beam flattened, sir, homogeneous flattened beam.
Okay. Okay.
After that will be the jaws, sir. Like it acts
No,
as
no, 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 no. We
um,
have monitor chambers. MU1, MU2.
yes, sir. Yes, sir.
After that, if you want to keep edge will be there. After that,
Yes, sir.
now you can tell. Now you can tell.
Yes, sir. After that will be the jaws, sir. Like upper and the lower jaws will be there, which acts as the secondary collimator, sir.
Very good.
Then will be the down will be the treatment counts.
So where is the MLC? No MLC in your machine? You said upper jaw, lower jaw.
Lower
Where is the
jaw.
MLC? Where
So
is the MLC?
these jaws will act as the collimators, sir. Below the lower jaw.
So in variant, you have upper jaw, then lower jaw, means X jaw, Y jaw, then you have as a MLC as a tertiary.
Yes, yes, sir.
Okay. In
Yes.
variant machines, you will have upper jaw, that means X jaw, lower jaw, Y jaw, and then only tertiary MLC will be there. But in the case of Electa, you don't have a tertiary MLC. Just they removed upper jaw, that means X jaw, they kept MLC there. That's why the space between gantry and isocenter is better in Electa compared to variant. So because Electa doesn't have one setup, because in variant XJA, YJA, then MLC. In Electa, they removed MLC here. They brought it to upper jaw replacement. Understood?
Yes, sir.
Good. We'll go to next question. Can you say something about this graph, madam? For
Yes, sir. We can see here
there are two lines. One is
two
red
lines,
color,
sir.
another one is
Yes, sir. One is the graph for the kerma, sir. Kinetic
okay.
energy released per unit mass, and one is for
Very
the
good.
absorbed dose, sir. So in the red bent graph, we can see here the build-up region, sir.
Okay.
It happens with the mainly this photon, sir. So initially, after beam interacts with the matter due to the production of the secondary electrons, and after that, uh, the secondary electrons and this dose absorption will be there in the matter, sir. So after this dose buildup will happen until the dose reaches its maximum. Normally it is at the depth of 1.5 centimeters for the 6 MV, sir. So after that, this secondary electrons, and there will be more attenuation, so the beam falls off, sir. The absorbed dose will be less. In the karma, we can say that it is just the energy transfer from the um, photon to the charged particles, sir. So it is continuous. It is the release of the energy. So the graph will be like
Yeah. So
follow.
I will explain you simply. So when the photons interact with the surface of the phantom, okay, for example, so the photons start giving energy to the electrons. They transfer kinetic energy to the electrons. Okay, the electrons gain kinetic energy. The liberated electrons having kinetic energy. This electron is transferred from the photons to electrons. So slowly, as the photons going deeper and deeper, the energy transferred to the electrons from the photons is getting decreased. That's why it is a continuous drag. But these electrons doesn't deposit. These electrons didn't deposit. Don't deposit energy immediately. They will travel and deposit. So initially, you don't have a kinetic. You don't have a absorbed dose. So it started here. After some traveling few mm or few centimeter, it starts depositing energy in the medium. That's why the absorbed dose, the red curve started build up. Once they release it to their maximum range, they will deposit more. Then after that, again, it will get reduced. So this is the kinetic energy released to the electrons, given to the electrons by photons. That's why it is the process is slowing down as going deeper and deeper. So the electrons will not deposit immediately. So they will start depositing, slowly depositing. So that's why this curve started build up. This is the observed dose. This is the collision curve.
Yes.
Next. Yeah, we'll go to next. Can you say something about what is these graphs, madam?
So these are different beam profiles of things. Sir, first one is of
1 second, madam. What is beam profile?
sir, beam profile is the it is the graph representing the dose distribution with relative to the at a depth and also field size, sir, and telling about the symmetry of the dose, sir.
No. Tell me something simple. I'll tell you. Okay, at any depth. It's not a matter of depth. At any depth. How
Okay.
the dose variation across the beam. You are
Dose.
moving across the beam. You are trying to measure the dose at each and every point across the beam at any depth. It can be 5 centimeter, it can be 10 centimeter. So simply you say the dose variation across the beam.
Okay,
Am I
sir.
right? So from one side of the beam to you are moving other side. So how the dose varies? When you are outside this side, you are here. You started measuring. You are outside the field size, less dose. You are coming close to the field size. It's increasing, increasing. You are entered into the field size. The dose is decreased. Entire field size it will be flat. Again you are started deviating. You are moving away from the field size decreased, and again you are moving decreased. So simply if you say
The dose.
so, yeah, this is the like this can be any side. Like from if you see water phantom, it has 2 dimensions, no? Cross plane, in plane. Am I right? Like beam is like a square. For example, 10 by 10 field size means you can see it's like a pyramid. It's getting divergent and it is coming. So crosswire is there, no plus mark. So you move crosswire from A side to B side. That means from patient left to right, or from gun side to target side. There can be cross plane or in plane profile, but profile means dose variation across the beam at any depth. Simply, how the
Yes,
dose
sir.
varies from one side to another side when you are moving. So now tell me what profile it is. What profile it is? There are different profiles you have seen here. Can you tell me what is the first one?
So it's a photon beam profile, sir. I
As of my knowledge, all are photon beam profiles here.
sir,
All 4 are photon.
cobalt
Okay.
6. Yes, sir.
Okay. Okay.
And the second one is when we the second one is with the flattening filter beam, sir.
Okay. What is this profile? That means what profile it is? Is it cobalt profile?
No, sir. It 6 MV profile, sir.
Some profile that is a photon beam from linear accelerator.
Yes, sir. Yes, sir.
From the profile from linear accelerator, because there is a small dip at the central axis region because
Yes,
of flattening
filter.
filter. So
Yes.
you can see this is a cobalt profile because you don't have any flattening filter in the cobalt.
Cobalt. Yes, sir.
This is linear accelerator profile. That can be 4 MV, that can be 6 MV. That we will discuss later. Okay, there is a small dip here also. That is because of flattening filter. What about this profile?
Sir, this is the profile after placing the wedge, sir.
Yes, because of wedge. Wedge have thicker side. So thicker side dose is decreased.
Yes, sir.
Very good. So what about this profile?
This is a flattening free filter beam, sir.
Flattening
Without
filter
the-
free beam.
Yes, sir.
So because of that,
So the there is forward scatter. That's why the in the central axis there is high peak, sir.
okay. Do you know any parameters? Just how do you know How do you make sure that the beam is flat? How do you verify this profile is correct? Do you know some parameters? How your physicist is verifying your what is this? Profiles are good. Profiles are okay. Tell me one thing. These profiles are okay or wrong profiles?
These profiles are okay, sir.
Okay. So any idea how to verify the profiles? How your physicist is verifying these profiles? Whether this profile is okay or not?
Sir, beam symmetry and the flatness.
Symmetry means?
Sir, dose uniformity across the whole whole under the curve, sir. The from the central axis to the end of the beam, the
Then flat.
should be
Then
uniform.
then
Flatness is uniformity across the whole field, sir.
but then symmetry means you said just now that one only, na? Uniformity both you're telling. Symmetry also you're telling uniformity and flatness also you're telling uniformity.
No, we mean symmetry is like left side and the right side, right halves and the left should be.
Yes, yes. As a left side, if you see, is it exactly mirror of right side or not? That's what the symmetry.
Okay,
This
sir.
off and this off should be same. If you fold it, it's like a mirror one. It should match each other. If you fold at the central axis, it should like match mirror one. So that is called symmetry. This side and this side. Flatness means how flat it is. Am I right?
Yes, sir.
It should be flat. That means it should have plus or minus 3% variation. Understood?
Okay,
This,
sir.
this is the flat. How flat it is. Do we need flat profile?
Yes, sir.
Why? You don't like these profiles? You don't like these profiles? Do we need flat profile? What is the advantage of flat profile? What is the advantage of symmetry profile? Why your profile should be symmetry?
So the dose distribution should be homogeneous, sir. And
Yes, in the tumor, dose distribution should be homogeneous across the tumor. So this should be flat. Then only the entire tumor will receive same dose. If you use this one, middle will receive higher dose, the periphery of the tumor will less receive dose. Then why you want symmetrical profile? Why you want to symmetry?
sir, because we are delivering, because we have to see the central axis. From there only we will be seeing, sir. So if it is symmetrical only, the overall dose distribution will be uniform, sir.
Okay. So sometimes you use off beam blocks. So you may block this off. It should be receiving some X dose.
Yes.
When you
Yes.
are blocking off this one, it should be same X dose. Na? If it is some tilted kind of thing like wedge profile, it will be higher, it will be lower. But as per our knowledge, if you block or if you block this one, the dose both sides should be same. So that's why you need a symmetrical profile. In the breast case and all you do na.
Yes,
Sometimes
sir.
you treat right breast. That time you will block the left side one. Sometimes you treat left breast. That time you will block the right side off. So in both the case, whatever it is, the beam should be flat. It should be same. Okay, next.
No.
Sir.
We have another 15-20 minutes, slightly speed.
Okay. Yeah, yes. Okay.
Oh, okay.
Okay. Madam, can you see this one? What it is? Can you say something?
So this is the
What curve it is?
photon beams, PDD of the photon beam, sir.
Very good. Can you say some parameters? What do you know about PDD? Is it really important in radiotherapy?
Yes, sir.
So what are the parameters? How do you know this PDD is correct? How do you verify it?
Sir, actually PDD is the defined as this ratio of the dose absorbed at any given point and to the reference depth on the central axis, sir. So
What is PDD, madam? Define PDD, percentage depth dose.
sir, it's a ratio of percentage ratio of the dose absorbed at any given point to the reference depth on the central axis, sir.
Reference cosmetic. Here it is completely Dmax.
Okay, sir.
What is the percentage of dose at any point with respect to Dmax? Simply.
Okay, sir.
So can you tell me what is PDD? A simple layman language.
Percentage depth.
Yeah, what is PDD? A simple language, a layman language.
Percentage of dose at various depths with respect to Dmax, sir.
Yeah. So as I said previously for profiles, profile is a dose variation across the beam. Am I right?
Yes, sir. Yes, sir.
Now this PDD is the dose variation along the central axis of the beam
Yes, sir.
with respect to Dmax. That's all.
With respect to Dmax.
It's a
Yes.
layman language. This graph indicates how your dose varies as you are traveling from one depth to another depth along the central axis.
Yes, sir.
Okay, good. So can you tell what is this, madam?
This is the PDD of electron, sir.
Very good. So can you say something about this tile portion?
So the tail is mainly because of actually it is a Bremsstrahlung reaction. I mean, when the interaction happens, it never be zero, sir. The tail represents that low dose which is releasing mainly because of the
Bremsstrahlung. It's a Bremsstrahlung.
Bremsstrahlung radiation.
I'm
Yes.
talking about electron. Am I right? You said this is an electron PDD, but you said this is Bremsstrahlung. How it is Bremsstrahlung?
Sir, when the electron interacts with the matter,
Okay.
the interactions mainly.
Then this should be also Bremsstrahlung, na?
Yes, sir. It will be also, sir, but the dose will be never be zero, sir. Once that completely electron loses its energy.
No, I will tell you. I will tell you. See, this dose is deposited by the electron traveling the electron in the electron beam. For example, 6 MeV electron, okay, or 8 MeV electron. This dose is deposited by completely electron. This you can see now. This style we call practical range. You read somewhere here.
Yes, sir. Yes, sir.
Till this level, this is the dose deposited by the electron. That is the practical range. That means the electron travel to up to that level. It deposited dose up to there, up to that level. This is completely dose deposited by electron. What is this style? Because from the electron, from the Linac head, when the electron is coming, the electrons will hit collimator materials and all, no?
Yes,
IZ
sir.
materials. When they hit IZ materials only, the X-rays will be produced. That X-rays depositing dose further. That is the dose, this one. The X-rays travel, na? The X-rays will travel further, na?
Yes, sir.
That X-rays, that means X-ray contamination in the electron beam. This is
Okay.
X-ray contamination from the electron beam. How did you get the X-rays? From the target, when the electrons are coming, they hit different materials in the head, like XJA, YJA, MLC. When they hit that one, they will emit X-rays. That X-ray contamination dose, Bremsstrahlung dose.
Okay, sir.
Okay.
Yes, sir.
But this one is mainly your electron dose. That's why up to this level we call it as what we call it as practical range. Practical.
Yes,
Yeah,
sir.
we can go. Can you say something about this one? This is very, very interesting. So clinically.
Yes, sir. This is showing the lateral tissue effect, sir. This graph represents the lateral tissue effect. Mainly when we use this low energy beams, and only if we are using APPA, when the lateral separation is more for APPA separation is more for a patient. This will happen, sir, because the dose distribution will be max at the levels and at the later levels, telling that peripheral tissues, and in the central the dose will be less, sir. So it represents that one, sir.
No. Tell me properly. It's a very clinical point. It's not less. For example, you have a patient with tumor at midpoint. You want to treat this patient with APPA. Which one you will select? You want to treat by APPA, parallel opposite beams.
Okay, sir.
So which energy you will select?
Sir, when we are using it depends upon the lateral separation of the antro AP separation of the patient, sir.
Okay.
If it's more than 20 centimeters, means it's better to use at least 10 MV energy, sir.
Yes, if you use higher energy, you will get uniform dose distribution. That means whatever the dose you are prescribing at the center of the tumor, the periphery also you are almost like a plus or minus 5% you will get. If you use low energies in the APPA beam, near the skin level, both side, entry and exit level, middle is a tumor. This entrance side, exit side, the normal tissue will receive more dose if you use low energy. So
Yes.
if it is less, if the patient separation is less than 15, 4 and cobalt is okay, but still if you have higher energy, better to use higher energy.
Yes,
Because
sir.
the entire distribution is uniform. Otherwise, what will happen? The tumor will receive 100%. The above and below the tumor is 120%, which you don't want.
Yes, sir.
So even if it is like if you have higher energy, go for higher energy when you are treating APPA. If the tumor is center, if there is no tumor at the entrance and exit level, understood? So
Yes.
if you go for higher energy in the APPA, you will get better homogeneous dose. That's why if you see 25 MV, the dose, see, it's almost the curve of red curve is matching with 100. Am I right? More homogeneous. But
Yes, sir.
if this is the 25 centimeter patient separation, see at the periphery, if you use low energy, higher dose is delivered. Higher dose is delivered. You want to deliver 100% dose, but here receiving 120. So more normal tissue subcutaneous dose.
Yes, sir.
Okay.
Yes, sir.
So this is the explanation. Okay. So we go further. Can you say something about this picture, madam?
Sir, in this picture, it's mainly it's representing the wedge angle, sir. The angle they are showing is this is that angle between the tilted isodose curve and the line perpendicular to the central axis of the beam, sir.
Yeah.
At mid dose depth is
You are
the
talking about wedge angle. You are talking about
Yes, sir.
wedge angle.
Wedge angle.
So
Yes,
wedge
sir.
angle is the angle between.
Tilted dose curve and the line perpendicular to the central axis.
Yes, not central axis. Many people will say central axis. No, it's wrong. It's the angle between tilted isodose line and
line
perpendicular to the central axis. This is the
yes.
angle, not this is the
Yes,
angle.
sir. Yes, sir. Yes, sir.
At any depth, you have to say any depth.
No, sir.
At any depth, you can say, or you have to mention a specific depth.
Dmax or at the 10 centimeters, sir.
No, not Dmax. Wedge angle will be defined at only one depth. Initially, they used to
50.
say, 1 second. Initially, they used to say 50% of the, where 50% isodose line, how much it tilted from that normal to the central axis. That is, but it was clinically insignificant because if you say 18 MeV photon, that's Dmax 18 or something 25 if you take, that's or 15 MeV if you take, it's 50% is 18 centimeter. So that is not a, what we call it as, that is not a clinically significant depth, like a 10 centimeter under clinical depth. So now later they changed the definition. So that you have to say it only 10 centimeter depth, not Dmax, not at 50 centimeter. That is a 10 centimeter.
10 centimeters. Yes, sir. Yes, sir.
At 10 centimeter depth, the tilt of isodose line from the normal to the central axis. Okay. So any idea about hinge angle?
Sir, hinge angle is the angle between this two intersecting beams of the central axis.
Two wedged beams. Yeah, angle between central axis of two wedge beams. So what is the clinical significance of hinge angle? What is the importance of hinge angle? You should know or no need to know?
Sir, it should be perpendicular.
Why did you learn this hinge angle definition? Because when you place two beams with a different angle, okay, so what wedge angle combination will give you the better homogeneous distribution inside the tumor?
Okay, sir.
So if you have two beams, you have a tumor, okay, patient body, you give two wedge beams. So which wedge you have to select? So which edge angle you have to select, that is given by hinge angle. So that mostly it is not always right. If the patient is too irregular, it is wrong. So you can see the, okay. Understood? So for example, you have a patient, you are planning to treat, you kept two wedge beams. So which wedges you want to use? Which angle is the optimal angle for this plan? If you, so there is a formula, there is a thumb rule. Use that thumb rule, like 90 minus hinge angle by 2 will give the wedge angle. So this wedge angle will give you the better distribution. That's what. But it is not always right in the modern era, because now you got a three-dimensional dose calculation. This is all in 2D era. Now the patient may have more unevens, more slantings. That time it may not work properly. But in olden days, yes, this is the method. Any idea about different types of wedges or anything you want to say something?
Sir, here.
Any idea about different types of wedges?
Yes, sir. Physical wedges.
That's what I told. Don't read the messages what they're typing.
No, I didn't see the message, sir.
Okay.
Physical wedges and dynamic wedges, sir. Dynamic wedge. So physical wedges are like, it has different fixed angles, sir. 15 degrees, 30 degrees, 45 degrees, and 60 degrees.
Okay.
And the dynamic wedges are like, we will use the jaws to get the wedge effect, sir.
Very good. How?
One more is like, we will.
How?
We'll use the jaw motion, sir. Like movement of the jaw will use as a like to simulate as the wedge, sir, the jaw, the placement of the jaw. And one more is like universal wedge, sir, which we
you understood, no? What you said, you understood?
Means we will place.
No, did you understand or not? Whatever you just said just now, you understood, no?
Sir, I know, not practically, sir. I know theoretically that we will
change. What will happen? That's what I want to tell you. What will happen during the beam delivery? During the beam delivery, one of the jaw will start moving slowly. So what will happen when it started here? It's coming. So it is absorbing now, when it is coming, entering into the beam. So this part will absorb more at the end of the beam. Am I right? This will absorb less. So because it is traveling from this side. So the edge profile will be created. Wedge beam will be created by using this jaw. There is no wedge. The jaw acts like a wedge. It is creating wedge effect. The speed of the jaw will define the different wedge angles.
Okay, sir.
You know anything? Other jaws like universal jaw, universal wedge?
Universal wedge, sir. We will use that 60 degrees wedge as the universal wedge, sir. By
No.
moving the 60 degrees.
No. Universal wedge means like in cobalt we will use individual wedges. Okay, that means for 15-degree wedge it is different for different field sizes. Width it is okay, length it will vary. So length it is okay, width will vary. You cannot use same 15-degree wedge for all field sizes. For different field sizes, even if you want 15-degree, so like a 35 by 10 width field size, you have to use one wedge. 35 by 15, you have to use another 15-degree wedge. So that we call it as a physical wedge or individual wedges. Even for 15-degree, you will have different edges for based on your field size. Same like 30-degree wedge, you will have 3-4 wedges based on your field size. So these called wedges. But in the case of linear accelerator, for 15, only single wedge will be there. Any field size, use that one only. Okay, 30 will be there. For any field size of 30-degree, you can use this one, 30-degree. Now we understood?
Okay, sir.
We don't use universal wedge because if you keep the universal wedge here, output of the cobalt machine will be decreased. So, but in the LENAC, we will play with dose rate. So you don't have any problem. So LENAC, we use universal wedge in olden days. Okay. In cobalt, we use individual wedges or physical wedges because for even 15-degree, different wedges will be there based on the field size. But here, single 15-degree, single 30-degree, single 45-degree, single 60-degree can be used for any field size. So do you know anything about, so now you said dynamic virtual wedge, yes? So anything another wedge like in electron and all, any idea?
Motorized wedge, sir.
Yeah, motorized wedge, very good. It is 60-degree wedge, okay?
Yes, 60-degree wedge, sir. Yes, sir.
Yes, it is a single 60-degree wedge. We call it as a motorized wedge, okay? It will come inside the beam, like open beam combination, wedge beam combination. For example, if I want to deliver 60-degree wedge, as it is 60-degree, entire full beam on time, it will be there inside the beam. Then in the phantom, it will create 60-degree wedge effect. For example, if I want 30-degree wedge, same wedge will come inside the beam, but it will not stay for full time. 50% of the time will be wedge, remaining open beam. Remaining 50% of the beam, open beam will be delivered. Now, open beam and wedge beam combination created 30-degree wedge. So this way, in electra, we use motorized wedge, okay, of 60-degree. With this help, open beam combination, wedge beam combination creates required edge effect. So in electra, we can create 0 to 60-degree, any wedge angle I can create. If I want 29-degree, I can create. If I want 30-degree, I can create. Even 32-degree, I can create. Any wedge angle I can create, because based on the open beam and wedge beam combination. Understood?
Okay.
For example, if I keep 25% wedge and remaining 75% I delivered open beam, then it will be 15-degree wedge. I kept 75% of the beam on time with wedge, remaining 25 open field, then it will be 45-degree wedge. Understood?
Yes, sir.
Good. Next, can you say something about these curves? What are these curves?
So these are isodose curves, sir.
Okay.
Of first is cobalt 60, sir, of isodose curves of cobalt 60.
Good.
Second is photon from the LINAC, sir.
Mm-hmm.
Third one is with the wedge, sir, in the
Very
path.
good.
And fourth one is electron beam isodose.
Okay. How can you say electron?
So because of this lateral bulging of the beam, sir, and this lateral bulging of the beam, sir, and the
Okay.
depth is less.
Very good. Okay. So can you just, I'm jumping up, because we don't have so much time, so I'm jumping. Can you say something about this curve? So any clinical significance? You are talking about electron. So you want to say some one or two, you want to speak some about 1 or 2 sentences about this isodose lines?
Yes, sir. It is limited depth.
That is okay. Electrons means limited depth only.
Yes, sir.
I'm talking about based on the shape of the isodose curves, isodose lines. So you can say clinical points.
Okay, sir. So we can use for the surface, like if you use for any surface tumors, it's better. We can use with the electron beam, sir.
No. I'm talking about based on these isodose lines, say something. Don't say generally what you can do with electrons. No. Based on these isodose lines, tell me something different, which is clinical related. Can I tell?
Yes, sir.
See, in this, from these isodose lines, the low isodose lines bulge out. Am I right?
Yes,
See, the
sir.
low dose isodose lines are bulged out. Not, but high dose isodose lines contracted. Can you see this one?
Yes,
They are
sir.
inside. See, 100% it is not coming edge of the field. Did you observe? This 100% isodose line is not coming up to field border. So they are contracted. They're concised, compressed. Yes. But low dose isodose line bulged out. So whenever you want to treat with electron fields, okay, compared to photon field, for example, you want to treat, there is a tumor of 9 centimeter tumor. Okay, you want to use 10 by 10 field size for photons, for example, but use bigger field size if you are planning with electrons, because your 100% your higher dose isolines like up to 80 or 90, they are contracted. So use bigger field size while treating electrons with electrons.
Yes.
Understood?
Yes, sir.
Not like photons. In photons, how much margin you will give around the tumor? Hardly 7 mm to 1 centimeter. Am I right?
Yes, sir.
But in the case of electrons, you give somewhat bigger.
Okay, sir.
The reason is higher value isodose lines are contracted, compressed.
Yes, sir.
That is the reason you have to use bigger fields. Somewhat bigger, not too much. Second thing, you talk about these low isodose lines. They are bulged out. I don't know how many people are having an experience. We used to do with the photon electron beam combination while treating head and neck tumors. In few years back, we do head and neck, 3D CRT head and neck. So we'll treat up to 44 gray in 22 fractions with bilateral fields completely. After 44, in the neck nodes area, to save the spinal cord, we will block the spinal cord with the help of JA or MLC. Okay, because we need to get the spinal less dose to the spinal cord. But how to treat if you block it, if you block it lower border, posterior border, we have to give electron dose because electrons will not penetrate much. So spinal cord will receive very, very less dose. So in this combination, I am using one field with photon, side by immediately with electron. So what will happen? These spread when it is merged with photon. Consider this side is photon beam is there. This side electron. Now this electron dose is going inside this side. This creates a hotspot.
Yes,
so we should be very careful while planning. You should give 1 or 2 mm gap also. Nothing wrong. Some doctors will give, some doctors, okay, they will take it. Understood?
Yes, sir.
So this will create hotspot when using the combination of photon and electron fields. Okay.
Yes.
Someone is giving 5 mm. I read in the messages. Okay. Can you say something about these graphs?
Yes, sir.
Yeah.
First is Bragg peak, sir, of the proton.
Okay.
And second one is second graph is representing spread out Bragg peak, sir.
Very good. Why they are like this? Any idea?
Sir, they have
Why the curve is like this?
sir in the so this in the proton actually the dose deposition at the end of the beam range will be maximum, sir, the dose deposition, and there will be immediate fall off, sir.
Yeah, as the electron speed decreases, the loss will be sorry, not electron, I'm sorry, the charged particle, proton. When the travels, initially it has higher speed. When you have higher speed, the deposition is less. As it is traveling deeper and deeper, its speed is getting reduced. Its speed is reduced. The square of the deposition will be higher, like inversely proportional. The speed decreases, so its deposition is more. When it is coming to almost zero, it will deposit all the dose at a time. It will make it almost zero.
Yes, sir.
So that is the reason. So how did you get this spread out Bragg, please?
Sir, by combining the various energies of the protons in order to achieve the complete target coverage.
Yes. So by decreasing slowly energies, for example, you know how many, what is the normal energy, highest energy of a proton therapy? Like, you know, like a photon linear accelerator, no? What is your highest energy?
15 MB.
15 MB, very good. So what about photons, protons?
Protons, I don't know, sir.
Up to 250, 270 will be there. So by using energy degraders, they will reduce the energy. So for example, you consider it is a 250. Next they will make it 240, 230, 220. This way they will spread out this. Why do you want to spread out this?
So in order tumor should get the
tumor is not a point. It has some size. So the entire size should get uniform dose. So by degrading the energy, so they will get a uniform dose in the tumor depth. Am I right?
Yes, sir.
Very good. Next. Now, okay. Do you have any idea about these machines?
Yes, sir. First one is tomotherapy machine, sir.
Okay, good.
And second one is ring gantry machine, sir.
Any idea what it is?
Halcyon.
So can you tell the basic difference between these two? Only one difference. We'll go to next question.
Yes, sir. The main difference between this ring entry and this tomotherapy is the tomotherapy will treat like the main principle is we'll treat like a CT scan itself, sir. We'll treat every slice during the treatment.
Yeah, slice by treatment.
Slice wise treatment. In the ring entry, it will be like whole treatment will be during the we will treat the whole volume, whole field in one rotation.
Yeah, yeah. It's like a normal conventional linac. 40 by 40 will be open. Whatever be the maximum field size of the Alcyon. It is from Varian. This is from Active. Both are not same. Don't think that both are like a CT bore. So both are ring entry. No. This Halcyon is a conventional linear accelerator. Our normal linac, 6MV linac. Okay. It will open 40 by 40 and it will treat entirely at a time like our normal linac. Okay. But it is rotating. It's a shape of CT scan. But in Tomo, even it is a ring entry, it's a treat slice by slice.
Yes, sir.
Okay. Slice
Yes.
by slice. So people will get confused. Both are same. Tomo and Halcyon. No. It's like it is equal to conventional linac. Because entire tumor will be treated at a time by modulating the MLC. But
Yes.
gantry is rotating. But here, gantry is rotating and treating slice by slice. Okay?
Yes, sir.
Yeah. Couch moves. Yes. Couch moves like a CT scan only. Here it will not move while treatment. So this is the Tomo. Tomo means slice. Next. Have you ever seen this machine?
Yes, sir.
What it is?
Cyber knife machine, sir.
Okay.
For SRS.
Okay. Only SRS.
SRS, SRT, and SBRT, sir.
Okay. So can you say something? So what linac it has inside? So how it will treat?
Sir, it has the 6MV linac energy beam itself, sir. It is
Very good.
treating with the X-rays itself.
Okay, good.
And
Like a 6MV low energy linac.
Yes, sir.
Like
Yes.
our conventional linac, but
Yeah.
collimator is very, very small.
Small. It will.
And these are different
beam.
cones also there. You can
Yes.
see the cones. Very good. Only mainly for SRS, more non-coupler and non-isocentric.
Non-isocentric treatment.
Yes, yes. So it has a synchrony option also. So live means based on the patient, even if your patient is moving, lively it can track the tumor. Okay, it has
Yes.
synchrony option. The tumor is moving, the head also will move. It will track the tumor live. It will not stop, gating under. It will stop when there is a tumor is not in the beam path. You know very well. But it has a symmetry option. If the tumor is moves, beam also will move.
Yes, sir.
So the same concept they brought it in Tomo also. The same synchrony, the live tumor tracking option, they brought it to tomotherapy also. Next. So sorry. So you know about these machines?
Sir, first one is gamma knife, sir.
Okay.
Second one is JAPEX. Is it bunkerless radio surgery?
No. Second one also gamma knife, but from Electa. This is just schematic diagram. This is a it's not a perfection, explicit something, a spirit something. This is a Electa's new model, gamma knife. This is schematic diagram. This is a real picture of the gamma knife. So any something know about gamma knife? Like how many cobalt sources are there? How many beams?
I think it 192 cobalt sources, sir. It will deliver the pencil beam for the accurate.
Yeah, you have almost 192 beams. 192 or 210 also there are some machines. Okay, so that means you have 210 directions you can treat the tumor. So mainly for SRS.
Yes,
and
sir.
trigeminal neuralgia, very small tumors. That's what. This is the Aspirit. Espirit. What is this? Electa's newest model.
Okay, sir.
This is the model. So can you say something about this?
So this is MR Linux, sir.
Okay, good.
So they have incorporated this MR along with the Linac for the treatment, sir.
Very good. What is the
They-
advantage?
Sir, mainly it is mm, this MR guidance will be there, sir, for the real-time imaging. And
Okay,
also has this adaptive radiotherapy, sir. So we can
what is the Linac energy? What is the MR? How much Tesla it is? Any idea?
Tesla it's 1.5, sir, with the 6 MB Linac, I think so, sir. I'm not sure with the Linac energy, but
6 only, only. 6 only.
so MRI which used is like 1.5 Tesla MRI, sir.
So what is the advantage of this machine?
That
What is-
visualization of the tumors will be better, like a brain tumors and all will be better visualized when compared with the CT, sir. We have.
Okay, that is the only option.
And it has this adaptive radiotherapy also, sir. So
Yeah, online adaptive.
yes, sir.
Yes, you have to do the online. Without adaptation, you cannot do it.
Yes,
You
sir.
have to do it adaptive plan. If there is no much changes, you can go ahead with old plan. But anyway, you have to do the adaptive. It will do the replan on your image,
Yes, sir.
that day's image, and it will check if there is more deviation. You can go ahead with the new plan. If it is a less deviation, you can go ahead with the old plan. But you have to do the adaptive plan. Okay, good.
Yes.
So, any idea about this one?
This is bunkerless Zapex radio surgery unit, sir.
Very good. Very nice.
Yes.
Why it is bunkerless? Is it possible?
Yes, sir. The outside shielding. I think that outside shielding, the machine itself has the outer shielding effect with the material, sir. I don't know exactly, but
See, actually, this shield is there now. It is
yes.
inside the room. This itself will shield the entire radiation because we are using 3 MeV, 3 MV X-rays.
Okay, sir.
So this because this is just the shell itself. What is it? Acts as a shield, and it's a low energy. You don't need much shielding. 3 MV, and it's only mainly for
Brain, sir.
SRS. Yeah,
Brain.
brain. Very good. So you have some idea about this one?
Yes, sir. It is SGRT, so surface guided
Okay.
radiotherapy.
Can you tell me something advantage, disadvantages? 1 or 2 words.
So mainly it has this advantage of this intrafraction motion.
Okay.
That setup accuracy will be better with this, sir, without additional
Okay. You
effects.
can
And
monitor the patient position continuously during the treatment.
yes, sir. Yes, sir. Yes, sir.
That is advantage. What is the disadvantage?
Mm. Don't know, sir.
Cost. No, not only cost. You cannot say cost. Cost is always
Time,
disadvantage.
sir. Time. More time the patient will be during the.
No. The main thing is, see, you are seeing the external breathing now. We don't know about internal.
Okay, accuracy. Okay.
Internal organ movements also there now. It's only external surface you are matching, trying to keep it. But we don't know what is that. Okay, it's a complementary one. Yes, you okay. It is an extra help because some patients you no need to have masks. Easy setup. You can easily set up, and you can monitor the patient throughout the treatment. Okay, the daily intrafractional monitoring it is possible. You can do some gating also, but the main disadvantage is you can matching this one externally, but we don't know internally whether it is matched or not.
Yes.
Yeah. Next. Can you say something about this one?
Dose
is
volume
this?
histograms, sir.
Very good.
And
Can you
it's a
tell one?
cumulative dose volume histogram, sir.
Okay.
Actually, these are like it's a radiation dose distribution across the, defined volume, how much that target and the OARs are receiving.
So how many types of DBHs are there?
Two types are there, sir, like differential DVH and the cumulative DVH.
Okay.
Differential one, it's like volume receiving the dose within specific volumes, it will be representing, sir. Cumulative, it shows the volume receiving that given dose, how much it's receiving. And for interpretation, normally cumulative will be more easy.
Clinically, we use cumulative.
Yes,
So
sir.
what is cumulative? Can you tell me?
It's a combined, sir, the volume, the whole volume, how much dose it will be receiving at least like given dose, how much volume it is receiving, it will be.
No. The volume receiving a specific dose or higher than that. Cumulative means, for example, volume receiving 20 gray means the volume which is receiving is 20 gray and higher.
Okay, sir. Okay, sir.
For example, volume receiving 20 gray is 30%. The meaning means, what is the meaning is, the 30% of the volume is receiving 20 gray or higher. Minimum 20 gray. That is the meaning.
Okay, sir.
So what is differential?
Differential is volume receiving the dose within the specific volumes, are like 1 cc, 2 cc, the dose bin within
No,
the.
it's not a 1 cc, 2 cc, you cannot say. Like it's a bin, 1 to 5 gray. How much volume it is receiving?
Okay, sir.
How much wax cells are receiving? 1 to 5 gray. 5 to 10, how much volume it is receiving?
Okay, sir.
If you sum all the volumes, it will be equal to the volume of the entire structure.
Yes, sir.
But it is cumulative, it's not like that. Okay. Next question. So any idea about this picture?
Yes, sir. DIVH, sir. Deep
Okay.
inspiration. It's representing this deep inspiration breath hold, sir.
Tell me what happens, how it works.
The patient takes a deep breath and holds.
Okay.
So increases the chest wall to the heart distance, sir.
How?
So when the patient takes a deep inspiration, lungs expand, sir. So,
Okay.
so the chest wall moves away from the heart.
And the lungs expands, heart will be moved downwards.
Yes, the heart
Chest wall move. Yeah.
just move upwards, and it reduces that. So it increases the distance between that when we are treating the breast or the chest wall.
Okay.
So when that mean heart dose will be reduced, sir. So
Is it helpful for all patients?
mainly left side breast patients will be more benefited from this, sir.
No, okay. In the all left breast patients, is it helpful for all patients?
Yes, sir. Like physically fit patients, sir, if they are.
No, you may not get always the advantage because the separation is not good. If you don't get proper separation, you will get just 1.5 grade difference only with
Okay,
DABH, without DABH. So
Okay.
find out at what threshold you will accept this. Like, how can you say, like if you are reducing 4 gray, 5 gray, or 6 gray, 7 gray, that is good. So what level it is not significant? It's no advantage. For example, you did one case with DIBH. For the same patient, without DIBH also you did. The only difference is 1 gray. Which one you will select? DIBH patient or non-DIBH patient? With non-DIBH, heart dose is like 6 gray. With DIBH, it is 5 gray. Or just 1 gray difference.
Sir,
Did you get the question?
yes, sir. Mean heart dose should be like with less than 5 gray, sir. If it is receiving 6 gray, means I'll go ahead with the DIBH itself, sir.
Okay. Find out actually.
Okay, sir. Okay, sir.
Next. Any idea about this plan? By seeing
Yes.
this distribution and all, you can understand something.
Yes, sir. Yes, sir. Yes, sir. Stereotactic radiosurgery.
Very good.
It's delivery of high dose, sir, like more than 12 gray, 12 to 20 gray of radiation to the well-defined lesions, like a very small.
How many fractions you will go in SRS?
Yes, sir. Single fraction, sir. In a single fraction.
No, up to 5 fractions, I think so. Please find out.
Yes, yes, sir.
In SRS also, yes. In SRS, up to 5 fractions, because we can treat 1 to 5, like 3 fractions, 27/3.
Sir,
So
okay,
up to
sir.
5 fractions they will accept. 30/5 or 35/5. So not only single fraction, up to 5 fractions, we call it as an SRS only. So
yes, sir.
any specific difference in planning and evaluation for SRS plans?
Sir, plan evaluation. So in the plan evaluation, mainly the beams are the different. So these are non-coplanar beams,
Okay.
not like other machines. And one more thing. And those
The plan
not
evaluation, plan wise or your contour wise, your immobilization wise, is there is something different or like a normal
Yes,
we
sir.
made?
Yes, sir. Immobilization that and this precision will be high, sir. It will be like under image guidance itself we have to treat. And
Okay.
the margins which we will be given will be lesser compared to the normal conventional planning, sir.
Very good.
And
We have to use special immobilization, which gives less than 1 mm accuracy,
accuracy, yes, sir.
deviation.
Yes, sir. Mainly what in our institute we'll be using like we have this cyberknife machine, sir. So our tracking will be for the brain tumor. It will be skull tracking itself, sir. So
Okay.
and we will give the margins mostly less than 2 mm margins, sir.
Okay. Planning wise, any difference? Like as you said, you are using non-coplanar. Why you want to use non-coplanar?
Because we are using different pencil beams, sir. So the dose to the normal adjacent normal tissues, and as it is multiple pencil beams and all, so that many angles it can be possible with the non-coplanar beams
Why
itself.
you want to give that many?
So to reduce the normal tissue dose, sir,
Yeah,
normal tissue dose
because you are giving dose per fraction is very high dose. Your fractional dose is very high. So you need to distribute the entire dose in the larger area, not in one side. So you have to give multiple beams, directions. So you spread the entire dose in different angles, different directions. Reduce the
Yes.
normal tissue fractional dose. Because fractional dose is very high.
Yes, sir. Yes, sir.
And okay, next, in the case of planning, okay, normally in VMAT and all, you will accept 7% higher hotspot. But in case of SRS, you can go up to 130%. And you will see the spill also, we will squeeze as good as possible because the
Yes,
fractional
sir.
dose is very high. So
Yes, sir.
there are other parameters, we call it as conformity index, gradient index, other indices also to evaluate the plan, the distance between 50%, 80%, 50% and 80%, 80% and 40%, 80% and 60%. There are different parameters. After planning, we will check all these parameters. They are well within the tolerance. Then only we will go for the approval.
Yes, sir.
Next, last, can you say something about this picture and can you?
Yes, sir. It is representing this total body irradiation, sir.
Okay.
And mainly we will use in acute lymphoblastic leukemias, AMLs, and some selected cases of lymphomas. And here they have shown this. It has the beam spoiler with the lung shielding,
Okay.
and patient is positioned in the lying position and lateral body position.
Decubitus we call it as.
Yes, sir.
So, do you know other positions and all?
One is
Do you?
in treatment, actually bilateral technique and APPA, sir. In
Okay.
bilateral technique, they'll be placed either in a seated position or like this lying down position.
Okay.
Mm.
Do you have any experience with TBA? So, which technique is good? Because there are different techniques, like a standing position APPA, lie down supine head position, and this lateral position. There is a sitting position, and there are many positions. So, which position is good? Any idea?
So with the extended SSD, bilateral technique using this lying down position is better when compared to rest of the things.
How can you say? This is bilateral. Even patient is lying down supine position also bilateral. Standing APPA also bilateral.
Okay. In this, we can actually midline dose.
See, dosimetrically, APPA is the best one. Okay, because APPA separation is very less. So you can deliver more homogeneous dose because your aim is throughout the patient body, you have to deliver a homogeneous dose. That is what your aim. So
Yes.
dosimetrically, APPA is good, but standing APPA is very difficult. So that people will select supine position. But in the supine position, patient comfort is more. 1 second. Dikshu? One second. Charging. 1 second. Charging better. One second. Charging. I'm sorry.
Yes, sir.
So in supine position, from right side to left side, the suppressed is more, less homogeneous dose, but patient comfort is more. And many pediatric patients we treat, so they are non-cooperative patients and some under anesthesia. So we cannot they cannot stand in APPA position. So this is the compromise. This is another technique, like a compromise between comfort. Like a supine is more comfort, patient comfort, but dosimetrically more inhomogeneous dose. APPA is more uncomfortable but more homogeneous. So this decubitus position is like a compromise between these two.
Yes, sir.
Yeah. Next, we'll go to next question. So regarding radiation safety, can you say something about radiation safety? Why do we need radiation protection? Do we need really radiation protection?
Yes, sir.
Why?
Sir, it is unwanted exposure of the radiation.
Just give me 1 minute. The last set 2 questions, 24 and 25. We are going to reach end. Okay.
Yes.
Okay. We have last 2 questions. Okay. Why do we need radiation protection? What is the basic principle of radiation protection?
Sir, why do we need radiation protection? Is to reduce the dose exposure, sir, unwanted dose exposure, and it's beyond
Why?
the. Sir, that for the patient who is getting treatment, it is okay, but the people who are surrounding it, they need not necessarily to receive this radiation, sir, this exposure.
Why?
Because of this
Do
stochastic.
you have any fear about radiation, madam?
Yes, sir.
You don't have any fear.
I have, sir.
You have, na? It causes biological effect.
Yes, sir.
There are 2 types of biological effects.
Deterministic and stochastic.
Okay.
Yes.
So what is the principle of radiation protection? Why do we need radiation protection? Because radiation causes biological effects. The biological effect 2 types, stochastic and deterministic. Stochastic means you know very well. So the principle is to minimize the stochastic effect and to completely avoid the deterministic effect.
Okay, sir.
You can avoid deterministic effect by keeping the doses under tolerance. Am I right?
Yes, sir.
Within the tolerance. Can you avoid stochastic effect?
Stochastic effect by
You cannot avoid. Even minimal doses can cause the damage.
damage. Yes, sir.
So you can minimize the stochastic effect.
Avoid the deterministic effect.
Yeah, completely avoid the deterministic effect. How can you avoid deterministic effect? By setting some dose limits.
Yes, sir.
How can you avoid the? How can you minimize the stochastic effects?
Reducing the threshold.
No.
Exposure.
By 3 principles again. Justification, optimization. Like you try to reduce as good as possible all your doses. Don't go for the limit. For example, spinal cord dose 50, or for example, our lens doses are 150. You want to go 100 because you are well within the 150 now. No, try to avoid, minimize. You cannot avoid, sorry. So by spending less time, by maintaining proper distance, by using shields, this way you try to, by using proper shieldings, this way you try to minimize the radiation dose. You try to minimize the radiation dose so that you can minimize the stochastic effect. By keeping your doses well within the tolerance, you can completely avoid deterministic effect. So that is the aim of the radiation protection. The aim of the radiation protection is, the principle of the radiation protection is to minimize the stochastic effect and to completely avoid the deterministic effect. So how to do these things? based on this, like a
And
justification, optimization, and setting
yes,
dose limits. By following these three principles, we can achieve the main principle of the radiation protection.
yes, sir.
Madam, any idea about this instrument?
Yes, sir.
Yes.
Yes.
Okay.
TLD, sir, thermoluminescent dosimeter, sir. It's
Very
personal
good.
monitoring device.
Okay.
So it's based on phenomenon of this thermoluminescence, sir, mainly.
Very good. Okay.
And so it has the 3 windows,
Okay.
mainly for the like measurement of the dose, like based on this high energy, high energy, and both high and low energy, and the low energy. So third window.
Okay.
First have this combination of this aluminum and the copper one, sir, and second one has the thick plastic filters, mainly for to see the beta uh, radiation, sir, and third one is completely, it's only the open window, sir, so we can see low energy is can be monitored based on this, sir. So the main principle is here is the
No. Here all will be enter into your
yes, sir, yes, sir, all will be
this
same.
disk. All will be there. Here electrons will be
Electrons will be there, yes, sir.
attenuated. So remaining low X-rays and high energy X-rays will be there.
Yes, sir.
Okay. Here only high energy X-rays will be there because low energy X-rays will be attenuated here. Here you will get all the doses. All will fall on this one because in empty window, na?
Yes, sir.
It will
All
fall on the disk. So this disk has information of high energy, low energy, beta particles, alpha particles or not.
alpha particles also, sir.
Is it right?
Yes,
Cross
sir.
check.
It's an open window, right, sir? So all radiation.
Think alpha particle will be absorbed in paper itself. So your TLD having one plastic plastic pouch and one paper also. So
Yes.
alpha will be absorbed in the plastic and paper. So how can reach the disk? So this TLD is not useful for measuring the alpha dose, alpha
Yes.
radiation dose. Understood?
Okay, sir.
This TLD cannot be used for dose received by alpha particle. Good. Second point. So here you cannot measure alpha because alpha is attenuated already by your class, by your protective things. Okay. Here the alpha is observed by plastic pouch and paper where your names, everything written. So here alpha will be observed, remaining all will be there. Here alpha plus beta particles is observed in the plastic window.
Plastic
So remaining low and high energy will be there. Here
yes.
low energy will be there, observed, alpha will be observed and beta observed, only high energy will be there. So based on that, they will apply all the things, they will find out your dose. Where to keep this one, madam? Where do you wear?
Ideally at the chest level, sir.
Chest level. Where do you want to wear it at chest level?
Sir, mostly we are expected to receive maximum radiation.
No.
Whole body exposure, if anything, is there that ideal at the chest level? If we place any whole body exposure, we can measure it off.
No. Where is our center of the body?
Umbilicus area, sir.
Umbilicus is the center of the body, but our chest is the center of the most of the critical organs, which is the center of the most of our critical organs. So it indicates whole body dose. So what is the units you will get here? What is the how you will get in gray? How you will get what dose you will get? Absorbed. So that's what it is: absorbed dose or effective dose or equivalent dose. Which dose it is?
Effective dose, sir.
That's why I told you not to see the messages.
I
Okay, it is an okay, no issues. Sorry, it's an effective dose, not absorbed dose, not equivalent dose, because they will apply already your tissue weighting factor 1. They will apply to your received dose, so it's an effective dose. So
yes.
when you can say it is a exposure is higher, exposure.
So if it's more than okay. No, sir, I know this only that yearly, annual, and consecutive dose limits, sir. But TLD, it will be monitoring 3 monthly. I don't know exactly.
Yeah, quarterly they will monitor. They will evaluate your TLD.
Yes, sir.
Am I right? So
yes,
now
sir.
tell me what is your when they call it as overexposure?
Sir, when if it is beyond 20 millisieverts per year, if it is consecutively for 5 consecutive years.
No. What they will do, for any quarter, if you received more than 10 millisievert, immediately they will inform to AERB and to us.
Okay, sir.
So 10 millisievert per quarter, you will consider it as a overexposure.
Okay, sir.
Per quarter, not per year. What is
Yes.
your occupational exposure tolerance?
20 millisieverts per year for 5 consecutive years, sir.
Average over. Average over 5
Average
consecutive.
5 consecutive years. Yes, sir.
In 1 year, how much you can cross? So 20 only, or you can cross more also, because you said over 5 years. Over 5 years you said. Average
Yes.
over 5 years you said. So 1 year I can go to 100.
No,
Other,
sir.
other years I can make it 0, 0, 0.
30, sir. 1 year.
30. 30.
30
As per AERB or NCRP?
AERB, sir.
Then what about NCRP?
NCRP, it's 20, sir. 20 per year.
20 is average over 5 years. I'm talking 1 year. How much maximum you can go? It's very, very important. So in 1 year, as per NCRP, you can go to maximum 50 millisievert. But as per AERB, you can go maximum 1 year 30. The reason is what they are telling. In 1 year, if you cross 50 millisievert, remaining 4 years, you have only 50, remaining 50 only to get average 20 millisievert or average over 5 years. So remaining over 4 years, you may not able to within the 50 millisieverts. That's why they made it to 30. So still remaining 4 years, you have 70.
Yes.
As per NCRP, the maximum radiation level can receive in 1 year is 50. But as per
50.
ARB, it is 30.
Yes,
And
sir.
when we call it as overexposure is 10 millisievert per quarter. If
Quarter.
any quarter, if received more than 10, immediately they will, they will intimate as they will consider it as a overexposure. I think we have done nicely. I'm extremely sorry for the delay. I cannot make it short. I cannot do it better than this. Patru sir. Is there or not?
Sir's name it is showing, sir.
I called him and I lost. So sorry, I cannot make it short.
Thank you.
Actually, they gave me 30 questions. I deleted many. Sir. Yeah, completed, sir. You want to say something?
No, thank you, sir.
Yeah, Mr. Srinu,
Yes, sir.
I think it is a total physics book, Khan physics you have discussed in 1.5 hours. It is a good thing. It is a good revision for the students. I many thanks to Mr. Srinu and presented by answered by the Dr. Sunayana. I am very much thankful to Dr. Sunayana and all these students and people who joined in the session, all the 7 days, extensive discussions and everything. I am really appreciate your presence, and I am appreciating all the presenters and mentors. Srinu, very, very, I am grateful to you. And don't worry, students. Go with pray God. Go with confidence. Just impress your externals, internals, examiners, and do your best. Best thing is you do it good at Osce. If you make a Osce examination better, you can acquire secure 80 to 90% from the 100 mark. It is very easy to pass the exam. Do long questions properly, nicely. 2 long questions, 20 minutes each. Then word rounds, four uh, 4 word rounds per each person. Word rounds means radiation reactions, small cases like these things. Then Viva examination is there, radiology, instrumentation, specimen, brachytherapy, all things will be there. Nothing to worry. Just go in confident, but no overconfident. Go with confident and just all the best. Thank you very much.
Thank you, sir.
Thank you,
so
sir. Thank you for the
Thank you,
opportunity.
Dr. Ajitesh also, and for this cooperation. Now I am leaving the show.
Yes, sir. Yes.
Thank you. Thank you. Thank you all.
Thank you, sir.